Log on, tune in, find out. Another good idea from Cambridge.
About choice experiments as applied in health economics.
Okay, thank you. And thank you, Jordan. That's, I think, quite a good background for my presentation. I should say, when I came to this whole area of choice experiments, or conjoint analysis as it was called, and I will give you a bit of history as to how I came to it. The work of Jordan and the colleagues that he spoke about in the work he did in the 80s was certainly influential in the thinking of myself and colleagues. I work at the Health Economics Research Unit at the University of Aberdeen. So I'm going to focus very much in this presentation on how health economists have used choice experiments over the last 20 years. Sometimes I find it hard to believe it's 20 years. That's one of those oh my god moments. I'm sure you've all had them. Okay, so what I'm going to do is look at choice experiments, and I know Jordan spoke about them a bit, but just give you kind of, I think some of you may not know what choice experiments are, so give you a brief background as to what they are. And also, given you about the background in health, some of you, and trials, etc., look at the whole debate about why choice experiments came to be used in health economics. And although they're not used solely within an economic evaluation context now, the whole introduction in health economics in the early 90s was around a debate that said within randomized controlled trials, the typical outcomes that are being used, such as quality adjusted life years or other clinical outcomes, weren't sufficient. And as Jordan indicated, we need to take account of patient preferences. And I will then go through the stages of a choice experiment and try and summarize where the debates are, at least in health economics, and I think in some other fields, about what the key issues are. And I'll draw on one example from a lifestyle intervention to try to illustrate that. It could really have been any example. And then summarize what I see as some of the key methodological issues. And I think it is worth saying that I think Jordan's presentation and talking about how econometrics has developed so fast is music to my ears, that maybe we don't have to go down that line, because I'm not an econometrician, so the whole idea that we can go back to weighted least squares is quite wonderful, actually. So okay, so I think just to summarize, and as Jordan said, we've seen each other's slides, and I had this feeling Jordan might run slightly over, so mine is slightly shorter than the 45 minutes, hopefully, so we should all finish on time for coffee. But the key thing to note about choice experiments, and I think it was what was one of the appeals of the technique to health economists in the early 90s. I'm not sure if you're familiar with other techniques that health economists use, such as standard gamble or time trade-off. Where in standard gamble, individuals are asked the probability level of indifference between a gamble and a certain outcome, with time trade-off, how many years at the end of their life they're willing to give up. I think one of the appeals of the choice experiment approach is that it's attribute-based, and the feeling that individuals are used to making decisions which involve trade-offs. And I suppose one of the obvious examples, and we can use many from many areas, about how when we're making decisions, we think about the individual attributes or characteristics, and then we make trade-offs and make decisions. And certainly over the years that I've been working in this area, 20 years, I've come across many applications of choice experiments. And I know when I teach students, they kind of all look at this one and they're not too inspired by it. But that's one of the most interesting I've seen is apparently we make these trade-offs in all aspects of our life. So even when we're choosing our partners, sometimes I say to students life partners and they look at me, no, we're just not thinking about life partners right now. But so we think about trade-offs. The idea is in all aspects of our life, even when we're choosing our partners. And the interesting thing about this study was apparently as we get older, our trade-offs change as well. So I'll let you think about that one. I'd also like to say that a student put this slide together for me, so I'm indicating nothing about my preferences with Brad Pitt. I'm not sure who I would put up there either. So, but in a health context, and I think many other applications, the typical question in a choice experiment looks something like this. So we have attributes and levels, we give individuals choices, and we ask them to make choices between a number of trade-offs. A number of choices are presented to individuals, and from that we can estimate their preferences. The second key thing, and something that does raise some debate in economics, is that this technique very much relies on individuals' responses to hypothetical questions. And perhaps in areas of marketing, choosing airlines, choosing cereals, individuals are used to making choices. So whilst it might be a hypothetical question in the survey, actually they are used to making those choices. Whereas in health economics, or in the context of health, quite often individuals are very unfamiliar with the type of questions that you're giving them. They're not used to making choices. It's the doctor that makes the decision about what treatment they have. So I think there have been some challenges for health economists in terms of individuals are quite often not very well informed when you begin the survey and actually explaining the context to them. And within the whole area of economics, there is a debate about should we be using data on individuals' actual behaviour, which we can observe from existing secondary data sources, or should we use data from hypothetical surveys? In health economics, to a large extent, we had no choice, because certainly 20 years ago, there were very few data sets available in which we could actually observe people's behaviour. So we were almost forced down the line in terms of valuation to use hypothetical surveys. But I think even with that in mind, it should be noted that surveys, or the experimental design experiments, discrete choice experiments, do allow you to evaluate interventions that don't currently exist. So if a drug company is evaluating a new drug, there is no data on demand for that because the drug does not exist. And also the whole kind of area of experimental design is very useful here, in that if you use secondary data, you tend to get lots of variables moving in the same direction, multicollinearity, whereas with an experimental design, whichever approach you adopt, and John Rose will talk more about this later, you're in the situation where you actually develop your own independent set of variables, really. So you're determining your data matrix. Of course, there is concern, I guess the key concern with these choice experiments conducted in a hypothetical context is whether individuals actually behave in reality how they state they would in a hypothetical context, and we will come back to the evidence on that. Okay, so an attribute-based hypothetical approach to valuation is two key issues. Within health economics, as I've indicated, there was a debate. I was studying my master's in health economics in the late 80s, and I was introduced to the way that economists at the time valued benefits, and that was through a framework known as the quality adjusted life year approach. Are you familiar with that? I mean, the QALY was introduced into health economics in the early 80s by the late Professor Alan Williams, and really it was a response to the typical approach to valuation in health economics at that time, which was really a very clinical approach, the cost per case detected or the cost per life saved, what's often referred to as cost effectiveness. And it's interesting to go even further back beyond that, when health economics began in the late 60s and early 70s. And I would like to say, this is from reading, I'm only having a 20-year oh my god moment, not a 40-year oh my god moment. From my reading, when health economists started to do health economics in the late 60s and early 70s, the obvious thing for economists at that time was willingness to pay. But willingness to pay was not well received in health economics. The whole idea of paying or trying to value individuals' lives did not go down very well. So if you do a search on willingness to pay in health in the late 60s and early 70s, you will see a few studies. But what we've seen is a move towards cost effectiveness analysis, and I think part of that was an attempt to get, as a health economists, we needed to work with the doctors, the medics, and therefore we adopted a very medical approach to valuation, such that in the field of economics, some economists think, what are health economists doing with their quality adjusted life year? What is that all about? So in the 70s we had cost effectiveness, and then in the early 80s the quality adjusted life year approach came about, and some of you may be familiar with it now. It's certainly still the valuation approach that bodies such as the National Institute for Health and Clinical Excellence still recommend. It's the type of information, if you're doing the evaluation part of a new drug or a new intervention, you need to know the quality adjusted life years gained in your submission to NICE. But as far back as the early 90s, there were debates in health economics about is QALYs really, are they really broad enough, and what about other aspects of the patient experience that matter to patients, such as how they receive that treatment, whether it's received with dignity, how long they have to wait, whether they have it in the location of their choice. Factors that were referred to as process utility and now perhaps the patient experience. So 20 years ago, this debate began, and I remember being the health economists in the UK have a conference twice a year, and I remember being at one of the conferences in the early 90s and a colleague saying to me at a conference presentation when conjoint analysis, as it was referred to then, a lot of confusion in the literature I think about names, but I remember someone saying to me, okay, well, sure, these things are important, process utility, but how as economists can we possibly value them, because we won't be able to take account of them in the QALY. And this really led in health economics to the introduction of choice experiments, conjoint analysis as it was referred to. And I was doing my PhD at the time, and that's what I did my PhD on. And at the time, a colleague, Professor Cam Donaldson, was looking at the reintroduction really of the more direct contingent valuation willingness to pay approach. So that's really the story of how contingent valuation and choice experiments came into health economics in the early 90s, very much in an attempt to go beyond a very clinical model of outcome. But what we've seen, trying to go backwards now, I think I'll revert to the okay. So, but what we've seen in health economics with the introduction of the technique within an evaluation context, the use of it much more widely now. I think it's a technique that's recognised to have huge potential. So it's not just used within an economic evaluation context, but to look at any policy question that can be broken down into attributes and levels. So we have studies, I think a very interesting area is understanding job choices. This has been used in Scotland, for instance, to try and understand the motivations of doctors and nurses. There are many people living in Scotland who love to go to the Outer Hebrides in their camper van for their holidays, me included, but the doctors don't seem to want to go and work on the Outer Hebrides. So we've got challenges about, and of course we have this in low middle income countries, how can we encourage doctors and nurses, health workers generally, to work in rural areas? So we're seeing an increased use of the technique in that area. Lifestyle behaviour, what type of lifestyle interventions can we introduce to encourage people to do exercise, to eat healthy, etc. So many applications. The drug industry have been using choice experiments and variations of it for many years in the area of drug development. Okay, this is a very simplified picture of what we aim to do with a choice experiment. I mean, if you look at the applications of choice experiments in health economics or in any area really, the main things that economists are doing are looking at, I think a key output is the marginal rate of substitution, as economists call it. That is, how much of one attribute is an individual willing to give up for more of another attribute. And the ratio of coefficients within your either simple or complicated regression technique will tell you this. This marginal rate of substitution is one of the issues that has led people to question how individuals actually answer choice experiments. Because as Jordan said, some people seem to focus on one attribute. And the idea behind the marginal rate of substitution is that people are making trade-offs, and therefore they'll be willing to give up a level of one attribute for an improvement in another level. Also common are the estimation of, as Jordan's indicated, willingness to pay. That's a monetary measure of value, so that within an economic evaluation context, for example, we can look at what a new drug is worth or what a new lifestyle intervention is worth. And also within the models, estimate probability of take-up. So if we introduce a new screening program, how many people will take it up? So that's the background, and this is this tries to sum up some of the key issues that come up when conducting a choice experiment. It's not comprehensive, but it attempts to pick up the key issues that individuals need to discuss and the issues that have been discussed in the literature when actually conducting a choice experiment. So one of the key issues is, well, what are your attributes and levels? If you're going to do a choice experiment, you need to be able to break your question down into attributes and levels. And also related, I think, to Jordan's point about the development of best-worst scaling, and I know Emily will present on this method tomorrow. How are you going to ask your question? Are you going to ask it in the traditional, give individuals options, and if you do give them an option between A and B, do you include an opt-out option, or do you move towards a best-worst scaling approach? The experimental design is a crucial issue. Once you've got your attributes and levels, that will give you a number of possible scenarios or configurations, and you need to decide which scenarios to present people. Then you need to decide how to collect your data, and then crucially how to analyze your data. And I think it's fair to say that over the last, I think the first 10 years in health economics really was spent actually getting familiar with the technique, looking at what it could do, looking at how it could inform health economics, and also in terms of the methodological work, looking at whether individuals obey the axioms of economic theory on which the technique is based. But really, I think the late 90s and the 10 years since then, and the 10 years plus, we've seen big discussions, and I think developments as well, in health economics around two areas. One, the experimental design of choice experiments, and also the data analysis of choice experiments. And thinking back to when I began using this technique in the early 90s, I remember I had a choice experiment. I think it had about 5 attributes, each with 4 levels, say. So that gave us 4 to the factorial 5 possible configurations. And I remember thinking, well, what do I do with these? You know, I wasn't from an experimental design background. I'd never heard of experimental design methods. And at that time, I came across a software package from a company called Speed. The software package was called Speed. It came from transport economics. And it produced an orthogonal array. And usually, miraculously, it always gave you, however many attributes and levels you had, you got 8 or 16 combinations, usually 16. And then, so I remember having these 16 scenarios and thinking, well, what do I do with them now? So, well, I'll create some choices. So randomly pairing them up. And this was in the early 90s. And that's what we did for quite a few years in health economics. We would take an orthogonal array from a software package, such as Speed at the time. SPSS does these simple packages, and then I realized, wow, there's actually catalogs out there that do these packages as well, that do these designs. So that was a standard, and some people would take the 16 orthogonal choice scenarios and take one out at random and compare everything to that. And that was, if you look in health economics, what was being done in the late 90s. And then it was actually, I think at the late 90s was when Jordan started doing some work in health economics with the people in Sydney at the Centre for Health Economics Research and Evaluation, SHARE, and then worked with Deborah Street and Leonie Burgess. And then they started talking about the whole world of design, which seemed to be a totally different world to me, of ones and zeros, and really that could be related to anything. And we were trying to take this world of ones and zeros and relate it to our choice experiments. And it was interesting then, because what we were getting quite clearly was we were using some of these designs which we understood. I think by this time we were starting to understand the principles of a good design better. And in fact, to a non-design person, they were very intuitive. They need to be orthogonal or near orthogonal, i.e. we don't want multiclinearity, and we want minimum overlap so that we get the most information from our choices. We want level balance, so we want things appearing an equal number of times. These seem to be the factors feeding into a design. So Deborah and Leonie, I think, and through Jordan, were very influential in the late 90s, early 2000s in terms of influence economists. because actually we all knew we couldn't publish anymore unless we upped the level of our designs, and we were on a crash course in experimental design really. As an economics student, we were never introduced to experimental design. So that was what health economists were really doing, and then we came across this software package called SAS, which, because of course when we used the designs that Deborah and Leonie introduced, then we still had the issue of, okay, this is a set of profiles, usually 16, how do we convert that to choices? And we were introduced to methods such as shifting, or random allocation with another design into choices. And then we came across SAS, and there also seemed at the same time to be a movement towards de-efficient designs, where you were more concerned with minimizing basically the variance around the coefficient parameters. But I think, to be honest, to economists, the appeal was that the computer would do this for us, and we were understanding by now a bit about design and what we needed to do, and so there's been a bit of a movement, I think, in health economics at the moment towards SAS producing de-efficient designs, and also flexible, I think, in terms of this issue we were having about coming into a world of 0 ones, and sometimes the scenarios presented didn't make sense. Well, SAS allows us to put constraints into the design, it allows for interaction terms, it allows for block designs. But then I never quite understood design really, and I have to say, I think in terms of the world of design, John Rose's introduction to health economics was great for health economists. And I remember being at a conference in the States a couple of years ago where John spoke, and for the first time some economists were saying, wow, I think I actually understand a bit of design now, so I've set you up to do a good presentation, John. And then John started talking also, if I'm right, John, you were starting to talk about introducing a priors into your designs, is that right? So actually using information we may already know about people's preferences, and also doing pilot studies to inform us about the parameters. So that's my relatively quick way of saying design has really moved on in health economics from the 20 years when we were taking a speed orthogonal array and randomly pairing it up into 8 choices, and probably not doing the most efficient thing. The other area where we've seen again big developments, leaps and bounds, is in the econometrics, and I suspect both of these developments, and particularly the econometrics over 20 years, is partly influenced by computational, the ability of the computer. But when I started doing choice experiments, we really used the random effects, binary, probit and logit, partly because we were using forced choices, and that's something I think to think about. So individuals were asked, would you choose A or B, and they were forced to choose one, and there was random effects, binary, probit or logit. And then as we moved towards, and I think rightly so, including opt-outs, giving individuals a choice to do nothing in effect, then we used conditional logit. Clearly you couldn't use binary, probit or logit. And then there's been a whole debate in health economics about the assumptions behind the conditional logit that are quite restrictive, and therefore developments of other econometric methods. The mixed logit being one of them, which drops the assumptions, particularly the IIA assumption, allows for multiple observations from individuals, which a choice experiment involves, and also allows for heterogeneity of preferences, although as Jordan says that term seems to be quite trendy now, but what exactly does it mean? To me as a non-economist, the big limitation of the mixed, a non-econometrician, the big limitation is we seem to have trouble running this. I don't know if it's just we're not very good at mixed logit, but and to get it to run and converge, we often need to make assumptions about the parameters which may not be valid, so we assume a normal distribution to get the model to run rather than because it's actually what we think about preferences. And I think part of the issue here is, and in fact I remember talking to, I think it was Geoffrey Swait about this model, and he said it's a sponge for data, you need a lot of data, so maybe it's to do with our sample sizes. So, you know, Jordan talking about weighted least squares, I say, get the papers out, Jordan, and I'm all up for that. So what I wanted to do is go through a study briefly. I've chose this just because really, particularly in a Scottish policy context, it's particularly interesting at the moment. I think it had quite a neat finding at the end. But really the main point is to try and show a discrete choice experiment in health and the issues that come up at each point. So the background to this study is the big problem we're having in Scotland, across the UK, and I think in many other countries about obesity and people being overweight and the implications that has for their health and consequently the health service. And we have a lot of, or some evidence about what works in lifestyle interventions, but what we have is less evidence about what people will actually do. And this is actually an important point when it comes to randomized controlled trials as well, because a randomized controlled trial can show that a health intervention or a drug is very effective, but if individuals aren't willing to take it, then you know it's not going to work. So the trials are based on people actually taking the drug. So we were looking at acceptability and the value of a lifestyle intervention. And I think one of the key moves we've seen in health economics more recently is the focus up until, I'd say, the last 5 years, or even just looking to the last 3 years, was very much on experimental design and econometric analysis. That's where we've seen a lot of development, and I think we learned a lot. I think perhaps somewhere along the line we may have lost or forgot the importance of the first stage of a choice experiment, which is to decide your attributes and levels. If you don't get your attributes and levels right, then the best design in the world and the most sophisticated or simple analysis cannot compensate. And what we've seen is a shift towards economists, I think, working more with qualitative researchers to understand better people's preferences through qualitative work as well as systematic reviews in the literature to understand what attributes should go into the choice experiment. So it used to be the case in a journal article you could say we use qualitative work to derive our attributes and they are shown in table 1. Whereas now you will need to say we use qualitative work and this is what we did. So people want to know more about how did you derive your attributes and levels. I think this was a nice study. It was a multi-phase study, so we used evidence from the systematic reviews on what works and also from phase 2, the interviews, which were carried out by qualitative researchers. We had 7 attributes. The issues in red are kind of issues that I think we need to think about when we're doing a choice experiment. I think Jordan's absolutely right, actually, that if you look at health economics, 7 attributes is usually the maximum. There is this question of how many attributes can individuals complete or take on board in a choice experiment, and maybe we have underestimated people's ability to have a broader set of attributes. Although I think one thing about health is that people are quite often not familiar with making the choices, so we need to always remember that. Okay, so these are the sets of attributes and levels. There were 7. A couple of things I've just highlighted in red. Risk quite often comes up when you apply choice experiments to health economics. And I think it's important to remember the evidence that individuals struggle with understanding risk. And there is some guidance in terms of explaining risk to individuals that will help them to understand it. In our pilot work, we found individuals were having trouble understanding risk. We've included a money attribute, which means we can get willingness to pay indirectly. And we've also got a time attribute, which allows us, therefore, to get value in terms of time. How much time would individuals be willing to give up? Okay, this is the attribute, the experimental design part. Our total set of attributes and levels gave us, as you can see, far too many possible configurations to ask preferences for all designs. For all scenarios. So we used a SAS design which generated 72 choices. We also felt that was too many choices to ask an individual. I mean, partly in a survey you're relying on people's goodwill to take part in the survey. If you look at health economics, I think that there is a move now towards asking people more choices. The early days were maybe 8 And then, in fact, some studies are as small as 4. And I guess I have a sense that people are just getting into it by the time you're saying, right, thank you very much, on you go. We did do a study where we compared responses to 8, 16 and 32 choices in terms of people's rationality, how well they did item completion rates, etc. And we found no difference between 8, 16 and 32. Maybe we haven't pushed people far enough yet. I'm sure Jordan thinks we can ask them more than that. So I think there has tended to be more kind of best practice that isn't based on evidence, and these questions do need to be researched more. Although having said that, from anecdotal evidence, people do start to get a bit kind of bored after a while, and I'm not sure if we can push them past 32. So in this study we gave 12 choices, and because this, as I've said, these are responses to hypothetical questions, usually you include some test of validity within there, often tests of rationality such as sense expansion, contraction properties, or a transitivity test, and I can talk to people more about them after, but usually there would be some test in there. This is a typical choice. Individuals, as I said, were presented with 12 choices. A couple of things to note. Firstly, this choice includes giving people the option of having their current situation. And in the early days, I think we often force people to make choices when we shouldn't have. And it was actually a debate that Emily started in health economics about our welfare estimates. And I think the danger is, if we force individuals to make this choice, that actually, if your maximum willingness to pay, say for a lifestyle intervention, is £5 a week, and you've got 2 options which are 10 and 15, then you're likely to overestimate demand. So you need to think, if you're doing a choice experiment, whether you want a status quo current situation. And I think, and crucially, from a lesson learnt many years ago, having done a big study in Scotland, if you do include an opt-out, you need to know what the levels are. So you need to think, what is the current lifestyle? So for instance, in this survey, we asked people what they currently did. You need the data on that opt-out to be able to analyse it. And remember, many years ago, including an opt-out for the first time and thinking, yes, I've done it, and then getting the data back and thinking, oh, but I didn't actually know the levels of the attributes for the opt-out. We've included a generic choice here, so lifestyle A and B are generic, and that they don't mean anything other than if you take away the levels of the attributes. And I think tomorrow, Emily, you're going to talk about a label choice, is that right? So where the label choices are quite often used in transport economics, where people are told it's a bus, it's a train, it's a car. So there's some issues to watch out for. Another observation, I think, over the last 20 years is we're experiencing, and I don't think it's just in the UK, lower response rates. People aren't so willing to answer these surveys anymore. We used to be able to get maybe to the general population 60 to 70% response rate. For this survey, even we piloted a couple of times, and we couldn't get a response rate higher than 13%. We thought it might be because it may be a sensitive issue, obesity, but then I think talking to colleagues both in the UK and elsewhere, that it is a bit of an issue, the response rate. So what we did for this was the first study. I think we used one of these internet panels where people are basically committed to responding to your choice or to surveys. So it was a web-based choice experiment, and I don't know, for those of you who've been involved in surveys, when you do mailed surveys, you basically send the questionnaire out, and then you have 4 to 6 weeks just to relax and chill and have your cup of coffee and reflect on life. Well, with your web-based survey, your data's all in 3 days, so be prepared. You don't have that kind of reflection time. I think that we've since done a couple of studies on the web, and I think you use them, Jordan, do you, the internet surveys? I think there are issues raised about whether people who put themselves forward for these panels are actually representative of the population and the extent to which we can make generalised comments. I think that's something to think about. Good job, I cut it short. Okay, so these are, I've got 5 minutes, okay, these are kind of, this is a conditional logit. Again, I'm not going to go into the detail of the different econometric methods, but conditional logit is still used in quite a lot of applications at the moment, I think, to be honest, partly because many people can't get the mixed logit to run. From a policy point of view, I think we found some interesting findings. There were certain people who always chose the status quo, and it's quite interesting to see that, I think, to observe people who won't change, and if they are the people who are overweight, then they're the people who, in trendy jargon now, we have to nudge them. And we also found a couple of interesting things, like people prefer, in terms of losing weight, they prefer exercise, where actually the evidence is that if you want to lose weight, the most effective thing to do is to change your diet. I mean, obviously it's a balance between exercise and diet, but actually it's far more effective to be changing your diet. And I read something, I can't remember the exact figures, but to lose a given amount of weight, you had to change your diet in a way that seemed reasonable to me, or else do 7 hours of exercise a day, and I think that really brought it home. And also we found that people did not like programs that involved support for management, and again the evidence is that these are the most effective. So there were some interesting policy findings. I think one of the most important findings from a policy perspective was we did this study to look at what people were willing to pay, as many DCEs have done. What we actually found was a negative willingness to pay, i.e. we have to pay people to do lifestyle interventions. So that was quite an interesting finding from a policy perspective, and gets into the whole debate of nudging and financial incentives. We didn't set it up to find that. Okay, so in summary, that was your crash course in DCEs in health economics. There are many issues, and I think the thing that I've learned probably over the years is the importance of working with a team of people who understand design, people who understand econometrics, and increasingly more recently people who understand qualitative research, and that's not to mention the psychologists who understand how individuals actually make decisions. So I've spoke about most of these issues. I think the big question really is one of external validity, and that is somehow setting up experiments where we can observe whether people behave in reality as they state in these experiments. To some extent, that would solve the whole questions around what is the best design, what is the best method of collecting your data, what is the best method of analysis. To date, I mean, most studies, or all studies, will attempt to look at what might be called the internal validity of the model. So they will check that the parameters move in the direction you would expect, which gives you some sense of validity. They will look at whether people include choices which are clearly superior. Do people choose them? Transitivity tests. But in health, at least, no study which has actually followed up with a choice experiment with a real-life experiment. And part of the problem is because to do that, you'd have to give people choice, the type of choices they have in the experiment. But I think that is the big challenge in the whole area of valuation in health economics. And then one final point, I think the other challenge, I mean, Jordan speaks about many applications of airlines and mobile companies, and I guess they're using these results from choice experiments. And I think in health, actually, the big challenge is actually to be getting our results used. We've had 20 years of choice experiments, but still the quality dominates from the policy agenda. So whilst you have a lot of studies maybe commissioned by the industry or local health boards, at the policy level, quality adjusted life years are still the dominant paradigm. So certainly for me, having worked in this area for 20 years, I would say in terms of future PhD students, I'd like to see external validity looked at more, and also an attempt to incorporate more into decision making as a tool to sit alongside the quali. That's me, I think. Oh, yeah, sorry. Just some useful references. Sorry, the first one is a review article that's just out about choice experiments in health economics, and the one by Emily and Jordan. The third one down is a user guide, which I think is very useful. And then the book by Henshaw and Rose is general, but I think very, very useful for those interested in the methodology.
You said that respondents often have problems understanding risks. How do you know that? Do they say explicitly that they don't understand it, or is it that they give inconsistent
Yeah,
references?
a combination. I mean, there's been a lot of work in this area more in transport and the value of life and risk in that area. And they've developed a number of aids to help people. And there are things like, don't ask in percent. People understand frequencies better than percentages, and visual aids. But yes, based on work that people are making in what you might call inconsistent responses.
Yeah, would there be a possibility of identify items for which the respondents would have no reason to be risk adverse, so that you could just assume that 50% risk of getting diabetes must be exactly half as bad as 100% risk, so you don't need to ask the questions about risk?
There are many choice experiments in health that don't have risk in. It's not always necessary, but in certain areas it is necessary. And I don't think, given that the whole idea of a choice experiment is to elicit public preferences, I don't think it's right to assume that something is half as good as something. We need to ask the public. I think rather than try to avoid the valuation task, we need to try and explain the risk better.
Can I comment on this? I mean, basically, psychologists and others have been studying this problem for about 50 years. There is no general consensus on how to provide information on risk and uncertainty in ways that either humans understand it or will make appropriate choices. We're about to put on a workshop with the University of Pennsylvania on this topic, bringing together 15 of the top experts in the world. None of these top experts agree.
Yeah.
So for people who are working in this field, whether you're working in clinical trials or otherwise, you really cannot assume that any human being can understand any of this risk information. We've just conducted 5,000 surveys in Australia on superannuation choices. These are retirement investment choices. In addition to which we ask numerical literacy tests, financial literacy tests, etc. People don't know any of this.
But isn't it often so that even if people don't understand the concept 30% probability, then they will still intuitively be reasonably good at making rational decision on the uncertainty?
Not obvious at all. I mean, just let's take something that we've had for dozens of years, namely weather probabilities. If you actually interview people as to what these probabilities mean that are given every day, you'll find that they differ all over the map.
Yeah. But they will still make the right decision
unclear.
whether not to take an umbrella if there's...
Unclear.
No? Okay.
And in the financial area, I mean, I don't know what countries you guys are from, but I'll just give you information that all of you need to be extremely scared about the long-term consequences of having turned investment choices over to single individuals. Every country in which this has been looked at, over 90% of the humans have absolutely no idea what they're doing.
Brent?
Yes. So if you're taking profiles from an optimal or an orthogonal design, then there's the question of how you group those profiles into choice sets. And one way you could think about that is using optimal or orthogonal blocking. So the question I have is that something that health economics people do? They think about, is the concept of blocking the choice sets into optimal block or orthogonal blocks part of that literature?
It has been
Do you
done.
want to answer it?
Well, what Mandy was talking about is it's a sequential process. So basically you generate it for one alternative, and then from my understanding is you randomly assign that same design to create the second alternative. In some cases they do use the fold over to do that, but then that's basically a Street and Burgess
So then
design.
they really aren't doing blocking.
You need to have, you need to have a spare orthogonal column, right? And in many cases, they're using saturated designs and they don't have the spare column.
The more modern designs through SAS, I do believe they actually do generate a blocking column. So you actually have a simultaneous generation process where you simultaneously generate all the alternatives as opposed to just one.
And as I understand it within SAS, so say SAS gives you 72 choices, you can put it in blocks, and then you can say how many you want within each block, and that they satisfy that the criteria of the good design. Whereas when you do it randomly, you're just taking them out of the 72, and they're the two approaches that have been used.
So
But
that-
hey, as health economists, we're open to learning about design.
So one thing that you said earlier was about level overlap being something that you wanted to avoid, right? But it seems to me that if people are making choices that are like Jordan was talking